Thank you so much for having me here. Thank you, Dr. Yuraj and Dr. Dean of Nair Hospital for having me to guide you and to implement the NABH standard. First of all, congratulations for taking this decision for the implementation of NABH standard. I worked with, with Andhra Pradesh state government for implementation of NABH fourth edition for the 18 medical colleges, of which 2 were reached to final. So I have read. Okay. So I know, thank you for your valuable time that you have come here and to know about the NABH. So we'll start. So what is accreditation? Anybody in this room has ever faced NABH accreditation or any other accreditation or certification? Yes. Excellent. So you know what is accreditations and how it is going. Anybody else apart from lab? No. So accreditation is a process. It is an independent body. First of all, it is located in Delhi. Quality Council of India. One of the board is NABH, that is National Accreditation Board for Hospital. So accreditation is always based upon the written and published standards. So what we call repeatedly is fifth edition. Fifth edition is nothing but the standard. So it has it has 651 standards for the implementations, and the reviews are conducted by the professional peer experts. Those are from medical backgrounds, and the aim of accreditation is always to encourage the organization for the further development. Now, what is the focus of NABH? Focus of NABH lies on 4 pillars. What are they? Safety. So whose safety? Patient safety is the prime importance. NABH always look at the patient safety. Then staff and employee safety, environmental and community safety, and information, education, and communication. So these are the main focus of the NABH standard. What are the outlines for NABH? So NABH, as I said, there are standards for which we have to comply. NABH is divided into the standard is divided into 2 aspects. What is first? First is the patient centric. The first pillar was patient safety. The first 5 chapters are dedicated for there are patient centric, and the another 5 standards are organization centric. So what are patient centric standards? So first chapter stands for access, assessment, and continuity of care, which is called as AAC. Second is care of patient, that is COP. Third is management of medication, that is MOM. Fourth is patient rights and education, that is PRE. Fifth is hospital infection control, that is HIC. What is organization-centric standards? The first chapter is patient safety and quality improvement. 7th one is responsibility of management. 8 is facility management and safety, that is called FMS. 9 is human resource management, HRM. 10th is information management system. So in brief, we will go out all the 10 chapters. What are the standards? Now this is the content of NABH. So we have seen 10 chapters. 5 are patient centric and 10 are organization centric. So this entire standard is divided into 10 chapters, as we say. There are standards. So how many standards? Total 100 standards are there. And in standards, there are objective elements. Okay. So we'll let you know what are those. Then objective elements are further. There are 651 objective elements. And about in 651 objective elements, there are commitment, core, achievement, and excellence. They are divided like that. This is our first round of NABH. So we will be assessed on commitment and core. So totally we have 660 objective elements to fulfill. So we need 80% of the score to get NABH accredited. Okay. Achievement and excellence, there are cycles of assessment. So first is final assessment, that is one assessment. Then after 1.5 years comes the surveillance assessment. Yeah. So there is called as surveillance assessment, which is after 1.5 years of you getting the accreditation. So entire accreditation is for 3 years. So at that time, these 60 elements called achievements are looked into it. And then something that is called reaccreditation. So in reaccreditations, there are excellence points or the standards or the objective elements which are looked in, that are 30. So since we are a beginner, so we have to focus on commitment and core objectives. Now, what is the methodology of survey? How the survey happens? So initial preparation has to be done by the hospital. Then there are document reviews, adherence to statutory and legal requirements. There will be a visit to various areas, and this visit will be sample-ized visit. So if we have 10 wards, probably 3 or 4 wards will be sampled. If we have 10 OTs, probably one of the OT in one of the building will be sampled. So this is always a sample size that we take. There will be the facility survey and the tour and random interviews. So interviews will be of the staff and the patient. Now, what as an organization we have to do to start with the survey? So initially the organization has to fill the application form, which is online. On the day of assessment, we need to thoroughly prepare with our scope of services, our resources, human resource, the doctors, the nurses, the paramedics, and we have to have a brief presentation of the hospital regarding brief introduction of the hospital, our organogram, scope of services, facilities that we provide, what is our quality improvement process, and what is the journey of implementation of NABH standards, and key monitoring indicators. Now, what are key monitoring indicators? We will see in a while. Then there are document review. Now, there are some mandatory documents which has to be there as an accreditation demands as a standard. One which many of the call is a Apex standard, Apex manual, chapter manual, or the quality manual. So this has to be there. Then there are departmental policies and procedures at the department level that they look into. There are various committees that have been formed. So their MOM, these are the documentation they will look into. Then medical record audit, prescription audit, adverse event that you had, or an incidence that was there and it was analyzed, and what corrective and preventive measures has been taken to prevent it further happening. And personal files of the staff. Statutory requirements are looked into very detail by the assessors when they come in. And what facility survey they look into is they take the facility safety rounds. All the facility that is within the premises they visit, like your manifold, liquid oxygens, electrical panels, DG rooms, biomedical waste storage, fire safety, all the fire safety regarding, where is the fire hose, or there is mock drill done, where is your fire tank, fire water tank, electrical safety, and biomedical and utility equipments. So these are the random interviews, staff interviews, and patient interviews they will look into. Basically, they will ask patient, what are your rights, what are your responsibilities, have doctor explained you something, which treatment you are undergoing. So these are the general questions they will just ask the patient to just know how the patient is aware or assessed by the doctors. Staff, they will like to know about your rights and responsibilities. Are you aware of departmental rights and policies and procedures? Incidents reporting, key KPIs that. Now, what are the challenges during all this process that we come in? So first and the foremost challenge is lack of awareness of the standard. So very soon we have the guidebooks that will be coming and that will be distributed to all of you. So guidebook is what? Guidebook is our Bible or a Gita. Everything that is written in the guidebook has to be implemented, or that has to be looked into, that is there on the end user side. Fear of unknown things, that is another challenge. So we have to be thorough with our guidebook pertaining to that department. Old infrastructure is always a challenge, and licenses are the challenges. License, before NABH happens, we should license is the one thing which NABH doesn't give us any points. It has to be complied with. License are every license regarding has to be fulfilled. I think it's in mute also. म्यूट में मेरे को आ रहा है ना, ठीक है, इसके लिए हम इधर कुछ चाहिए होती है. Okay. Manpower requirements. So for doctors, as of now, we don't have the ratio, patient ratio, but nursing we do have as per the nursing council. So we have to be compliant with the nursing council ratio per patient. the standard operating procedures and manuals, training for all category of staff. So NABH is a ground level implementation where we won't be assessed sitting in this department, but the ground level, the end users will be questions, and how percolated we the systems and the process are assessed at the end user level. So adequate training for all the category of staffs has to be there, and inadequate resources, if we have to have, we have to rectify beforehand. So these are the challenges that we face. Now, what are the key points in implementation? So these are the keys. If we have this in place, so NABH, achieving NABH will not be a problem. So what is that? Strong management commitment has to be there. And I think that is there. We need to have a quality coordinator. We need to have a quality team in place. We need to have chapter champions. 10 chapters are divided, and those people will take care of the chapter that are assigned to them. Understanding intent of every objective elements will help. Functioning committees on paper will not help, but functioning of the committees will help us. Assigning roles and responsibility with timelines and follow-ups regularly will help us to achieve the NABH. Involvement of staff, obviously, training, internal audits, follow-ups, and indicator and monitoring system. Now, points to remember: any non-compliance that comes during the internal audit or the rounds should be taken as an opportunity to improvement. First and foremost thing. We should not just close the NC for sake of closing it, but we have to look into it seriously so that it will not come up again. And it is a continuous learning process. And we have to have an established system for continuous monitoring and sustainability. I always say achieving NABH is not very difficult. It is very easy to get NABH, but sustaining NABH accreditation is extremely difficult. So sustainability is the one. When we have a strong system in place, it will be easy. Now, how after all this thing, how the decision is taken that one organization will be certified or accredited? So once the assessor goes with their report, they will also share the non-compliance that they have found during the assessment to the coordinator, NABH coordinator. So they give one more chance to rectify the non-compliance which they have found. If there is anything that we can, tell the assessor this, we have this, and show the evidence, they will knock off the non-compliance. The rest of the non-compliance are uploaded on the system. So there will be first cycle of non-compliance where we'll have to close the NCs, which we call non-compliance, share the evidence online. Then the principal assessor again will review the non-compliance and the evidence that we have shared on the portal. If he's satisfied, he will accept it. If he's not satisfied, he will reject it. And the second cycle of non-compliance is given to the organization. The second chance, what we call. The second chance, we have to be extremely careful in closing the non-compliance. Once the second, we accept whether the assessor, principal assessor, accept or don't accept, the case goes to the accreditation committee for the further decision. So accreditation committees looks after the principal assessor report, the non-compliance that is accepted or non-accepted in the second cycle. And based on that and other things, the accreditation committee takes the decision. Now, what are the parameters or the criteria that will define us to qualify for the final assessment or the accreditations? So we have core objective elements should not be less than 4. Every core we have to be achieve 4 marks. No individual standard more than one objective element need to score 2 or less. Average score of individual standard must not be less than 4 and chapter must less than be 4. If you score 3, we need to have an action plan with the timelines. Now, always remember the final assessment is marked or it is only based on the core and commitment. So we have all 651 objective elements, but we have to look only for core and commitment. We will not go in excellence and achievements. Now, what is required by the, these are the mandatory committees that NABH look into. So any organization going for NABH need to have CPR committee. It is cardiopulmonary resuscitation committee has to be there. Blood transfusion. Local authorization for transplant if the organization has transplant in place. Pharmacy or therapeutic committee, infection control committee and infection control team, safety committee, quality committee, internal complaints committee, and medical record audit committee. Pharmacy committee, minimum they have to meet once in 3 months. Infection control committee and safety committee, NABH requires monthly meeting of the committee needs to be there. The rest of the committees you can decide, but at least once in 3 months the committee should meet. And quality committee also should have once in a month representation. Now, what are the mandatory manuals that will require? Quality improvement manual is mandatory. Apex or chapter manuals are mandatory. Infection control manual is mandatory, and safety manual is mandatory. This manual has to be there for an organization. Now, what we talked about key performance indicators. So there are total 32 key performance indicator. Now, this key performance indicator will apply to different department, and every department needs to have this. And the data is collated every month. The data will come to quality committee or the quality team. They will collect the data and present the key performance indicators. Now, what are the indicators? Time taken for initial assessment of indoor patient by the doctors. These are mandatory key performance indicators that NABH looks into. Number of reporting area per 1,000 investigations. So this will be both for lab and radiology. 100% percentage of adherence of safety precaution by the staff working in diagnostic, medication error rate, percentage of medication chart with error prone. So this, there is an annexure part with the guidebook which has the details or talks about the details of what the indicator is. So there is a numerator, there is a denominator, and there is a multiplication. And this remarks or the indications is also written with the NABH standard. So as and when it comes, we will distribute to you. Percentage of inpatient developing adverse drug reaction, number of unplanned return to OT, number of surgeries wherein organization procedure, there is a procedure to prevent adverse drug event like wrong site, wrong patient, wrong surgery has been adhered to. Number of transfusion reactions, standardized mortality rate ratio in ICU, return to emergency department within 72 hours with a similar presenting complaints. Incidence of hospital acquired pressure ulcers after admission, catheter associated urinary tract infection, ventilator associated pneumonia, central line associated bloodstream infection rate, surgical site infection rate, hand hygiene compliance of nursing and doctors, percentage of cases where who receive appropriate prophylactic antibiotic within a specific time frame, percentage of rescheduling of surgeries, turnaround time for the issue of blood and blood components, nurse patient ratio for ICU and wards, waiting time for OPD patient, waiting time for diagnostic, time taken for discharge, percentage of medical record having incomplete or improper consent. Stock out rate of emergency medication, number of variation observed during mock drills, patient fall rate, percentage of near miss, incidence of needle stick injury, appropriate handovers during shift change of both doctors and nurses, compliance rate to medical prescription in capital letters. So far, any questions? Should I go ahead? Now, these are the mandatory codes that needs to be functioning or in place in the organizations. What are they? Code blue. So code blue is for adult medical emergency. Do we have a code blue? Do we have a code blue? Code white? No, code white is for what? Now, please, pediatric. Code pink. So do we have any system for infant abduction? No. Okay. Code red. Code as such. Okay. आता कोड कशासाठी असतात? This code they have written, code red, code white. generally this is हमारे जो visitors or patient है ना, they should not get panic, कि something has happened, and uh, because the panic comes, and all the chaos happens in the hospital if something happens. So that's why we have these are universal codes. Okay, so if there is any fire, so we announce as a code red, code orange for hazmat spill. So hazmat will be all your ethers, acetones, highly inflammable acids and alkalis. And in lab, people will be must aware because they have lots of reagents and this thing. MSGS for all. Yeah. So same will be need to be implemented in other OTs and wards where there is a stock of ethers and other chemicals. So this will also go for blood and body fluids also. Okay. And if we have a nuclear department, then isotopes. Code yellow for internal and external disasters. So disaster, we have to be well prepared. Known this organization, I think you will be prepared, but there has to be a systematic way of having internal. What will be the internal disasters? Exactly, fire. Very right. Very appropriate. A fire could be an internal disaster where we need to evacuate patients, wherever there is a short circuit and fire is out of control, where you cannot extinguish or it has gone beyond our control. So it is an internal disaster. External, we all know what it could be. Black is bomb blast. So being a Mumbaikar, I think we will all aware of the bomb blast, and this they will check in Mumbai, especially because if they come in an higher hospitals, they will. And code violet is for violence. Now there are mandatory. Yes, yes. See, if we say fire, fire, what will happen? Every will get panic. And there will be chaos in the hospital. Every patient, every visitors, every staff will start running here and there. So our security or a management will not able to, manage them or control them with such things. So that's why there is a code is there. Now, if we say code red, our general public will not understand what you mean by code red. So we will get time to stabilize them and evacuate or take action appropriate to that particular area. So that's why there is a codes that is there. Now documentation, the most challenging thing that's come in, and organization thing is big thing is documentation or the SOPs or the policies or the procedures. Now in fifth editions, when I was on the technical committee of fifth edition, this part was taken care very well, because there were bias of the outlook. They used to go only show the documentation of these that. So there was a lot of paperwork that organization asked us to look into it. So because of them, we said let's decrease the documentation. So there are only very specific few things that the NABH asked as a documentation, or you have a policy and procedure. Now what are they? So scope of the services is the main thing that we need to have in written. What is your registration and admission process? Managing patient during non-availability of bloods. How you assess the priority of clinical needs according to the patient. So if there is an emergency, you will ask the stable patient to stay back, and you will give access to the emergency patient first. So basically this is for those are in OPDs or in registration counters. Transfer in, transfer out. For lab, you must already there this procedure collection, identification, handling, safe transportation, and same is applicable for the radiology department also. Discharge of patient living against medical advice, uniform care is provided. Do you have telemedicine? No telemedicine. So this is excluded. Emergency services or the casualty, or what we call, there has to be a triage. Patient found dead or patient on arrival. So this has to be written a document or a SOPs. How a call for a patient transport is received. So if you receive a external call for the ambulance, so this is the ambulance service or the emergency services. So how you manage those calls? Nursing care in the hospital, various clinical procedures, transfusion of blood and blood component, uh, policy procedure for intensive care unit or SSI units, infection control manual, obstetric services, antenatal services, pediatric services, neonatal cares, prevention of child or neonatal abduction and abuse, procedure on sedation, anesthesia, surgical services, prevention of adverse drug event like wrong site, wrong patient, wrong surgery, treatment guidelines for transplant patients, uh, management of vulnerable patient, risk of fall, pressure ulcers, deep vein thrombosis, restraints, both physical and chemical, pain management, end of life care, pharmacy services, verbal orders, dispensing of medication, return of medicines to the pharmacy, self-administration of medication, medication brought from outside of the organization, and capturing of near misses, medication error, and adverse drug reaction. Procurement, storage, stocking, issue of implant prostheses and medical devices, informed consent process, patient complaints, cleaning, packing. This is for CSSD. So cleaning, packing, disinfectant, sterilization, storage, and issue of the items, reprocessing of single-use instrument, equipment, or device. Breakdown of sterilization system, equipment replacement, identification, disposable of equipments, medical equipment replacement and disposal, procurement of medical gases, handling, storage, and distribution, recruitment process. This is HR, training, disciplinary grievance. Now this is medical records. Who can write into the medical records? You have HIMS, so who can overwrite, who cannot write, who has the rights, who can log in, who cannot log in. Integrity of medical records. Once the medical records are entered, do you change it? You cannot change it. Yes. So what is the process? If there is a need of change, is there is a process or there is no change? How to access to the information of medical records? Who has the access? Once the files go to medical record, if there is any need, to access by the patient itself, by their relatives, or by the doctors. So what is your process? How you release the information to the patient? And of course, by the other agencies like police or any other who ask for the documentation of any patient. So how you release the document to them? So these are the general, aspect of a standard requirement and the NABH requirement to certify any organization as an accredited. So these are the minimum requirement that NABH looks into. I'm saying minimum requirement. So far, so clear. Any questions, any doubts? Because after that, we will go into the standards. You want to take any break? Because you are the key coordinators that will help us to, implement the standards. Too difficult? We will make it easy for you. Each specialty wise, is it any like what needs to be needed? Like pediatric, pediatric. What are the requirements? There are specific things, but chapters are divided into those. In those chapters, there are things. So for pediatric, yes, there is a clause of a COP which talks about pediatric department and a pediatric service that you'll have to implement in your pediatric department. Apart from that, as we said, code ping has to be very active in your patient identification has to be there. There will be hand hygiene, there will be biomedical equipment. So all the support services also will get implemented to your pediatric services. Almost all. Now, government is the first time we are getting this application. It is already done. Mumbai, I don't think any of the municipal hospital is accredited, but in South there are. There. Shall we go on the standards then? So this is now henceforth we will call the chapter as AAC, COP or FMS or HRM. So will not take access, assessment and continuity of care. That's why the acronym is there. Now here we will see only the core and commitment things. So these are only the standards. Huh? Objective elements are not here yet. So the objective elements. No. So I will tell. Now this AAC1 is the standard. I'm sorry. And these are the objective elements. So A, B, C, D. So in AAC1 standard, there are objective elements 4. And all the 4s are core and commitment. So only the core and commitment are displayed on the screen, which we need to have a final assessment, only that. Now here it says the organization define and display the healthcare services that it provides. The first is scope of services that has to be there. Now healthcare services being provided are defined. So it has to be defined or it has to be displayed. Now intent of this is given in the guidelines. So that's why we need to have a guidebook with us. No? So how to display or how to define will be our next question. So that answer lies with the interpretation which is in the guide. So at present, we won't be going into that depth. It will take a lot of time. But my next visit, by the time you will have the guidebook, you can come with the individual queries to me. I will rectify those and will try to implement those as far as possible. So the scope of services has to be permanently displayed. It has to be in language that it can be understand to your patient or your customers or the consumers. It has to be in a place where it is easily visible or available to your patients. So which could be that area? Correct. OPD. Entrance and OPD are this thing where you have a scope of service. Now what are the scope of services? The services that we provide. What we provide. So we have, and no, this is only clinical parts we are looking. We have physiotherapy, we have medicine, we have surgery, we have transplants, and number of all the services. What we don't have, that also has to be displayed because patient should not come and then go back saying that the service is not there. So what services we do not provide? हमारे यहाँ कौन सी सर्विसेज अवेलेबल नहीं है जिसके लिए हम पेशेंट को रेफर करते हैं? वो तो आप ही बता पाओगे। है ना हमारा सिटी स्कैन? तो उसके लिए भी अपना अलग प्रोसेस रहता है। देयर इज अ ब्रेकडाउन, दिस इज कॉल्ड इक्विपमेंट ब्रेकडाउन। जब इक्विपमेंट ब्रेकडाउन होता है तो हमारे पास क्या प्रोसेस है? वी हैव टू डिस्प्ले, वी हमको अगर जरूरत पड़ता है एडवर्टाइजमेंट देना पड़ता है कि हमारे पास ये सर्विस अवेलेबल नहीं है अभी के लिए, तो वो उसका भी एक प्रोसेस होता है। न्यूक्लियर मेडिसिन है हमारे पास, तो वो सर्विस हमारे पास नहीं है ना, तो दिस इज एक्सक्लूडेड, वी कैन राइट न्यूक्लियर मेडिसिन इज नॉट देयर। और क्या नहीं है? साइकेट्री वार्ड है, साइकेट्री वार्ड है, कीमो है, रेडिएशन है, ओके। सो सिर्फ न्यूक्लियर मेडिसिन नहीं है। बर्न्स बर्न्स यूनिट नहीं है हमारे पास। और क्या नहीं है? कम्युनिकेबल डिसीजेस, that is कसूरबार, that we don't have ना। बट हम अभी सिर्फ कॉम्प्लेक्स की बात कर रहे हैं, विद इन प्रीमाइसेस की बात कर रहे हैं। सो डू वी हैव ओपन कॉक्स? ओपन कॉक्स एडमिट करते हैं यहाँ पे, दैट्स तो ये हमारे एक्सक्लूडेड सर्विसेज। और एनएबीएच कहता है कि अगर आपके पास ये सर्विसेज है तो उसके रिगार्डिंग आपके पास डायग्नोस्टिक सर्विसेज ट्रीटमेंट देने के लिए अवेलेबल होना चाहिए। So that's what the second clause says about. No, services should have diagnostic and treatment services suitably qualified personnel who provide outpatient, inpatient, and emergency coverage. So whatever you service you enlist, ensure that you have proper resources to give facilitate that service. Now each department need to have their scope of services with the inclusion and exclusion. So if you have pediatric department, So what are there you include? So if neonatal care is there, we have it. So we are, except outside babies, yes. We have level 1, level 2, level 3, yes. That's the services defined should be displayed prominently in an area visible to all patient and visitor in a bilingual this thing. So anything that is we have display has to be bilingual. So one thing is English is there. So second is the state language that we see. So what is our state language? We have to display in that language. All your signages in your department, just have a look. If they are only in English, get it to bilingual. All the signages, I'm saying. Now, once the patient is there, once the scope is there, then it comes for the, we have well-defined registration and admission process. Now, objective elements is that they need to have a proper, documentation. What is your process on registration and admission of the process? And also it is how you include unidentified patients. So you have a very good system in HMS, which I have seen how to register the unknown patients also. So very good. And all patients who have unique identifier numbers. Now, why unique identifier numbers? Remember the first pillar of NABH that focus upon? What was it? Patient safety. Now, how we will help the patient safety in a unique number? Patient identification, most important. So what are your two identifiers? Do we have two identifiers to identify the patient? So we should have two identifiers to identify the patient, whether the patient is. Why we need to identify the patient? To prevent the adverse event. To prevent that. So right treatment has to go to the right patient. That's why you have to identify the patient, whether it is the right patient or not. It starts from there. If you have to give a chemo drug to some patient, and if some patient, both the patient's name are XY and XY, so how you will identify which XY to give which chemo? That's why the two identifier are important. So I worked with HN. So we had a patient name and date of birth as a two identifier. And used to always ask the patients, no, we were never telling कि आपका नाम ये है या आप ये है. No. So it's like, अच्छा, आपका नाम क्या है? We used to ask patient, what is your name? And we used to tally with the barcode that we have. So patient name and date of birth has to be a match. Now, why date of birth is very easy for own patient, we know that what is our date of birth. So somebody have unique identifier number as IP number, because patient will never know what is their IP number. No, their name, two names could be the similar. And another was a phone number. The phone number is a little bit difficult. So date of birth is very easy to remember. So we have to come to the common conclusions where we can have two identifiers will be easily as per the system of the NAR hospital, which are the two identifiers that we'll have to identify the right patient. This registration, anybody from registration and admission here? No. So we can skip this. Now these are transfers. Transfers in and transfers out, or the referral to the patients. So this is mostly the clinical part, clinicians, nursing and the doctors. So we need to have transfer in, transfer out, or the referral to another facility. And one more thing is look into during the transfers, or the referrals, the clinical staff should accompany the patients. So if it's a critical patient, then the doctor has to go with the patient and hand over the patient to the receiving organization or the receiving doctor. And transfer summary has to be there. So there has to be initial assessment when the patient goes into the ward. So it has to be OPD, almost everybody, daycare patient, your inpatient and emergency patient. It has to be done by the qualified doctors, and it has to done with a defined time frame. Now, what is this time frame defined? The NABH is defined within the time frame within 24 hours. And an emergency patient, we can define within 3 hours or the 2 hours. So based on that, so remember our key performance indicator, the first indicator that we looked into it, what was that? I will take back to you. Yes. So what is the first key indicator? For the intubation by the doctors. Now this is linked to your AC4C objective element. What the AC4C objective element tells about? So you got it from where your first indicator came. So it came from this. Initial assessment performed within the defined time frame. Okay, this also include the nursing assessment also at the time of initial assessment, and it is documented. Once the initial assessment done, standard says it has to be a regular assessment also. And periodic, this can be defined by the organization. Once a day, twice a day. And outpatient need to inform about their next follow-up. And whoever is telling them or looking at it has to document the thing of the reassessment. Also, organization guidelines and implement process to identify early warning signs of change or deterioration in clinical condition for initiating a prompt intervention. Now, these are again clinical things that we need to see what are the early warning signs, where we can deteriorate the patient and you can shift the patient once you see this warning signs. Lab services, infrastructure, physical equipment, I think lab person is there. Only you have a micro. Anybody from a lab? Only your micro is NABH, not the entire lab. Okay. So lab has to have a physical and equipment adequate for the scope of services that the lab is providing. Human resource adequate info, they will check. They will also check who supervise the investigations reported and the SOPs. Now we need to have defined turnaround time for all the tests. No, and we need to define the critical limits for each test, and the same shall be documented. And what NABH also requires is if there is any critical value. So for HB, you found it like 6, whatever your defined level is. If it is 6 or 7 or 5, then you know this is a critical value and immediately inform to the treating physician or the treating surgeon. So that needs to be documented. That is called critical reporting registers. So who has informed which value to which doctor has to be written, and who is the receiving person from the end user's name also has to be written, and what time it was given, information was given to them, because this is critical. The doctor may need to transfuse them, need to take some actions if the HGT or anything is very high, which needs immediate intervention of the doctors. That standardized format for the reporting of the lab investigations. And if there is anything that is outsourced, then it has to be a proper MOU with the other organization. Lab quality. So quality assurance program, verification, validation, quality of the test, calibration, maintenance, corrective and preventive actions. Lab safety. And same also goes to imaging service. Anybody from imaging? इमेजिंग से कोई है? X-ray, MRI, CT scan. So the only difference here is legal requirement, because all the radiological or imaging services needs regulatory ARB clearance. Rest is the same. So safety program. So lab has a different safety this thing. So radiation safety program is implemented. Radiation safety needs to be documented. Now this talks about continuous and multidisciplinary approach of patient's care. So they want a doctor has to be responsible from the admission to the discharge. Patient care is coordinated in all the departments. Information about the patient care and response to the treatment is shared among the nursing, clinical, and other care providers. Handover has to be there. If there is a transfer, it has to be done in safe manner. If there is a referral, it has to be documented. Then patient, now we have seen AACs from patient, it enters to the organization, now is going out of the organization. Everything that is happening to the patient from the entrance to the discharge is in AAC. So discharge process has to be documented. Discharge process has to explain to the patient or their relatives. It has to coordinate it among all the staff. If there is patient going against medical advice, the consent has to be signed, and their complications and whatever outcome, if they leave the treatment in between, has to be explained in the patient's own language that they can understand. And discharge summary has to be given to all patients, irrespective of patient is going proper discharge or it is going lava. Now, what needs to be there in a discharge summary? Content of the discharge summary is written. Name of the patient, their unique identification number, name of the treating doctor, date of admission, date of discharge, why the patient was admitted, what were the significant finding, what was your diagnostic, not the provisional but the final diagnosis, what was the condition of the patient at the time you are discharging the patient, what are the investigations that you carried out, if there is any procedure that was performed, what was the procedure, who has done it, under what it was done, what was it significant findings of the procedure, what was the medication that was administered, and what is the treatment that you have given, and what is the treatment that they need to be on, what is your follow-up advice to them, in a manner that they understand is clearly written. So it is not BDS or TDS. You have to clearly write before food, after food, morning, evening, that way. And instruction when and how to obtain urgent care. Now, when and how to obtain urgent care will depend upon the patient. It is an ortho patient, surgical patient, or medical patients. It will differ from why the patient was admitted. So when, if there is a surgical patient, if you have fever, kindly report, because fever will implies there is a surgical site infection. That's why patient gets the first spike of fever. Now, if there is fever, there is vomiting, whatever it is, and how to obtain, you can contact on this number. You can directly come to the emergency department, as this is how to obtain. So when to obtain and how to obtain. And in case of death, there has to be a summary. Now this talks about our first chapter, AAC. So clear so far? I know it is too much. We need to stop, or a second time we will take next time. Or do you want to continue? Next time? Okay. Any questions meanwhile? Okay. Yes, sir.
Whatever the changes you advise, how we are going to implement so that it can move forward. That means we have to give suggestion to the team, or we have to give suggestion to the particular department, or we have to give. So what?
Okay, so this will totally depends upon how the functioning of your organization is. How the things will. Now, for example, today as a team, we visited two of your areas. That was one of the ward and registration, admission, and the OPD. Key findings, that were generalized cleaning has to be there. If you open any vial or any medicine or any tubes or ointment, the first opening date has to be there. So these are the basic things, which has to be there. So why this is because of the infection control. We don't want our patient to get infected. Doctors and nurses do lots of effort goes in for the patient care. And if we don't take care of this general small things, then patient can land up into infection control, surgical site infection or whatever type of infection. So long I don't know how far your system is well versed in capturing this infection. So if we see today, we have saw like patient safety was the first aspect. So the wards, there was no side rails, you know. Then cleaning part, the surface cleaning, your floor cleaning, what solution do you use, what mops do you use, how frequently you clean your water to use.